Welcome to our third and last video on spinal cord diseases. Let's begin. In this lecture, we'll discuss poliomyelitis, amyotrophic lateral sclerosis, and Horner syndrome. Let's start with poliomyelitis. We will discuss definition, clinical features, diagnosis, and management of poliomyelitis. Poliomyelitis is an acute infection that damages the anterior horn cells of the spinal cord and lower motor neurons of the brainstem. The responsible pathogen is poliovirus, which is a neurotropic enterovirus. Let's discuss the clinical features of poliomyelitis. As we mentioned, the infection affects the anterior horn cells in spinal cord, therefore causing low motor neuron lesion. This is seen as acute flaccid weakness and diminished or absent deep tendon reflexes on physical examination. When the infection affects the lower motor neurons of the brainstem, respiratory and cardiovascular failure may result. Notably, the sensation is intact. In addition, aseptic meningitis is a common presentation in poliomyelitis. The patient presents with fever, nausea, headache, and nuchal rigidity. To diagnose poliomyelitis, clinical findings are highly suggestive. However, lumbar puncture is usually performed. The cerebrospinal fluid analysis shows moderate pleocytosis and elevated protein. The gold standard and confirmatory test is isolation of virus from stool. The diagnosis can also be confirmed by CSF PCR. Management of poliomyelitis is supportive. This includes pain management, physical therapy, as well as mechanical ventilation in case of respiratory failure. Let's do a review question. A 5-year-old boy is brought to the emergency department by his parents due to high fever and acute weakness for 2 days. The patient complained of leg weakness yesterday. He vomited 3 times en route to the hospital. He is not vaccinated due to parental beliefs. The physical exam reveals flaccid weakness of lower extremities along with positive Koenig and Brudzinski signs. What is the most likely diagnosis in this patient? This young boy presents with high fever, vomiting, and weakness. The physical exam reveals flaccid weakness of lower extremities along with positive Koenig and Brudzinski signs. The acute onset flaccid weakness and the signs of meningitis raise strong suspicion for poliomyelitis. Poliomyelitis is even more likely given he is not vaccinated. Therefore, the most likely diagnosis in this patient is poliomyelitis. Let's move on to our next topic, amyotrophic lateral sclerosis. We'll discuss definition, clinical features, diagnosis, and management of amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis is also called Lou Gehrig disease. It is a progressive neurodegenerative disorder which causes both upper motor neuron and lower motor neuron deficit. Let's directly move on to the clinical features. The typical presentation of ALS is asymmetric limb weakness. Features of UMN lesions include spasticity, hyperreflexia or exaggerated deep tendon reflexes, and pseudobulbar palsy, particularly dysarthria and dysphagia with increased and normal gag reflex. Let's remember here the difference between pseudobulbar and bulbar palsy. Pseudobulbar palsy is caused by upper motor neuron lesion of cranial nerves 9, 10, and 12, whereas bulbar palsy is caused by lower motor neuron lesion of cranial nerves 9, 10, and 12. Features of LMN lesions encountered in amyotrophic lateral sclerosis include flaccid weakness, fasciculations, muscle atrophy, and bulbar palsy, particularly dysarthria and dysphagia with absent gag reflex. So we can note that the patient presents with overlapping features of both LMN and UMN lesions. Finally, let's remember that respiratory failure is the main cause of death in patients with ALS. This is due to paralysis of respiratory muscles. The diagnosis of amyotrophic lateral sclerosis is primarily clinical. However, electrodiagnostic studies can be performed. This includes electromyography, which shows features of acute and chronic denervation, and nerve conduction studies which show normal findings. Neuroimaging, such as MRI, is performed to exclude other diagnoses. Riluzole is usually used in the management of amyotrophic lateral sclerosis. It prolongs the survival and slows the disease progression. However, some of the associated side effects include dizziness, weight loss, asthenia, and elevated liver enzymes. Asthenia is lack of energy or strength. Let's try a question. A 67-year-old woman comes to the physician due to progressively worsening hand weakness for the past 6 months. The physical exam reveals flaccid weakness along with 1+ deep tendon reflexes in both upper extremities. Spastic weakness and 4+ deep tendon reflexes are noted in both lower extremities. Sensation is intact throughout the body. What is the best pharmacologic management option for this patient? This elderly woman presents with progressively worsening hand weakness for the past 6 months. The physical exam reveals flaccid weakness along with 1+ deep tendon reflexes in both upper extremities, indicating damage to the ventral horns of spinal cord, a LMN lesion. Spastic weakness and 4+ deep tendon reflexes are noted in both lower extremities, suggesting damage to the corticospinal tracts a UMN lesion. Sensation is intact throughout the body. Lower motor neuron signs in the upper extremities, upper motor neuron signs in lower extremities, and intact sensation are consistent with the diagnosis of amyotrophic lateral sclerosis. The best pharmacologic management option for this patient is riluzole, which slows down the neuronal degeneration and prolongs survival. Lastly, we will discuss Horner syndrome. We'll discuss definition, etiology, neuroanatomy, clinical features, diagnosis, and management. Horner syndrome is oculosympathetic paresis. It is caused by a lesion along the sympathetic pathway that supplies the head, neck, and eye. There are many etiologies of Horner syndrome. However, the highly important ones are Wallenberg syndrome or lateral medullary infarction, cervical cord trauma, Pancoast tumor, carotid artery dissection, and carotid endarterectomy. Here's an illustration showing the oculosympathetic pathway. It consists of 3 neurons. The first and second neurons synapse in the lateral horn of thoracic spinal cord, while the second and third neurons synapse in the superior cervical ganglion. I love to annotate here the difference between preganglionic lesions and postganglionic lesions that cause Horner syndrome. A preganglionic lesion disrupts the pathway before the superior cervical ganglion. For example, Wallenberg syndrome and Pancoast tumor. On the other hand, a postganglionic lesion disrupts the pathway after the superior cervical ganglion. For example, carotid artery dissection and carotid endarterectomy. Horner syndrome has the characteristic triad of ipsilateral meiosis, ipsilateral ptosis due to paralysis of Mueller's muscle, and ipsilateral anhidrosis. Ipsilateral anhidrosis is found only in central and preganglionic lesions. In other words, this manifestation is absent in postganglionic lesions. Let's take a look at this image of a patient with Horner syndrome. We can see the meiosis and ptosis. The diagnosis of Horner syndrome is largely suspected based on clinical features. However, to confirm the diagnosis, we use cocaine or aproclonidine eye drops. Cocaine inhibits the reuptake of norepinephrine, hence induces dilation of pupil in a normal eye. It has no effect on an eye with impaired sympathetic innervation. So, anisocoria of 1 mm or more after applying cocaine eye drops is confirmatory for Horner's. Aproclonidine is a strong alpha-2 agonist, hence decreases norepinephrine release and results in slight constriction of pupil in a normal eye. However, aproclonidine is also a weak alpha-1 agonist and results in dilation of Horner's pupil that has de-innervation supersensitivity to alpha-1 receptor. So what we need to know is that reversal anisocoria after applying aproclonidine drops is confirmatory for Horner's. We can either use the cocaine test or aproclonidine test to confirm the diagnosis of Horner's. To determine if the responsible lesion is preganglionic or postganglionic, we can use the hydroxyamphetamine test. After application of these eye drops, anisocoria of 1 mm or more is positive for a postganglionic lesion. However, this test is not routinely performed. Neuroimaging, for example MRI, can be performed to identify the cause of Horner's. For the management, we need to treat the underlying cause. A 68-year-old man comes to the physician due to droopy eyelid for the past 4 months. He noticed he cannot properly open his left eye, and his left pupil is smaller than the right one. When he plays football with his grandchildren, the left side of his face does not sweat. He also complains of severe shoulder pain, which is worse at night. The patient has been smoking 2.5 packs of cigarettes per day for the past 50 years. The physical exam is otherwise normal. Which underlying condition most likely accounts for this patient's current complaints? This elderly man reports a droopy eyelid for the past 4 months. This finding is known as ptosis. He also noticed that his left pupil is smaller than the right one, so he has left-sided meiosis and resultant anisocoria. When he plays football with his grandchildren, the left side of his face does not sweat. This sign is consistent with anhidrosis. Ptosis, meiosis, and anhidrosis are the classic signs of Horner syndrome. The patient also complains of severe shoulder pain, which is worse at night. He's been smoking 2.5 packs of cigarettes per day for the past 50 years. Given his shoulder pain and extensive smoking history, the most likely underlying condition that accounts for this patient's Horner syndrome is Pancoast tumor. Here's an image showing how the Pancoast tumor looks like on chest x-ray. Let's end our lecture with a board-style question. An 11-year-old male presents to the emergency department due to an acute onset of fever, nausea, and headache. His parents are unable to speak fluent English due to having recently immigrated to America, and a translator is called in. On physical exam, there is generalized flaccid weakness as well as diminished deep tendon reflexes bilaterally. There is also significant nuchal rigidity present. When the patient's neck is flexed by the physician, the patient's hips and knees flex in response. A complete blood count returns with all values within normal limits. Based on the most likely diagnosis, what is the next best step in the management of this patient? A. Broad spectrum antibiotics. B. Chest x-ray. C. Lumbar puncture, or D. Electromyography. This 11-year-old male presents with acute onset of fever, nausea, and headache, nuchal rigidity, flaccid weakness, and diminished deep tendon reflexes. Additionally, he is a recent immigrant, meaning that he may not have received all his childhood vaccinations. The positive Koenig sign indicates inflammation of the meninges, aka meningitis. Since the CBC is within normal limits and not showing leukocytosis, we can assume the meningitis is not bacterial in nature. The presentation of acute onset of aseptic meningitis with headache, fever, nausea, and nuchal rigidity along with unknown vaccination status is consistent with poliomyelitis. In the management of suspected poliomyelitis, a lumbar puncture with CSF analysis is often performed first, thus making answer choice C correct. Here is a slide reminding us of clinical features of poliomyelitis. Let's discuss other answer choices. Answer choice A is incorrect because broad-spectrum antibiotics are not used in the management of poliomyelitis since the etiology is viral. Answer choice B is incorrect because a chest X-ray could be used in the management of Horner syndrome if a pancreas tumor is suspected, not in poliomyelitis. Answer choice D is incorrect because electromyography could be used in the diagnosis and management of amyotrophic lateral sclerosis, not poliomyelitis. And that concludes this section.